Okay, I think we'll start off because we have to finish it somehow today. Um, okay, so we'll start off, where we left yesterday. Um, so we have done the ward rounds, we have done the X-rays, the pathology slides, as well as the instruments. Okay, now we're moving on to the gross specimen. So they usually keep the gross specimen of a particular site, and you can be asked, any sort of questions in that particular site. They usually ask very general questions, nothing too specific. Okay. Okay, Dr. Raja, what do you see here?
Hello.
Ah, yeah, you're audible.
This is a gross specimen of a long bone, which shows that there is a solid mass, yellow to white in color, with areas of hemorrhage and necrosis, which is arising from the metaphysis, extending into the diaphysis, and also causing destruction of the cortex, more likely some malignant metaphyseal tumor
Yeah,
consistent with osteosarcoma.
yeah, good. So that's the perfect description for this. So here you can get all the osteosarcoma questions. Okay. So for an age of in the 20s to 30s, what is the most common bone malignancies you get to see?
In 20 and 30s, the most common is osteosarcoma, giant cell tumor of the bone, lymphoma,
Yeah.
and
So yeah, so 20s and 30s is osteosarcoma and Ewing sarcoma. And like you said, if you go 30s to 40, it is GCT and lymphoma. Okay. Now,
lymphoma.
in elderly group, like if we go above the age of 50, what do you see?
Above the age of 50, it could be metastatic from some primary, like, for example, from prostate or from breast. It could be myeloma,
Okay, plasmacytoma. Okay.
plasmacytoma,
Anything else you can think of?
lymphoma,
Yeah, a lymphoma can also present, and also chondrosarcoma.
and okay.
Okay, so that's it. Now, I want you to quickly tell me the answers to this. What is the treatment protocol for osteosarcoma?
Treatment protocol for osteosarcoma is multi-agent chemotherapy. Could be IAP chemotherapy or MAP chemotherapy, followed by assessment, surgery, and then adjuvant chemotherapy.
Okay, so what sort of surgery would you like to do, ideally?
We like to ideally do the limb salvage surgery.
What are the contraindications for limb salvage surgery?
If the absolute contraindication is if there is no power, the limb is non-functional. And relative contraindication are that, for example, if there is neurovascular bundle encasement, if there is any major vessel involvement, if there is not a good response to neoadjuvant chemotherapy, and if the tumor to bone ratio is very large, that the margins won't be achieved for closing, and
Yeah, so wide variety of reasons.
yeah, immature skeleton also.
Yeah, so all those neurovascular bundle involvement, joint involvement, if there's progression on neoadjuvant chemotherapy, if you have a pathological fracture, if you have a large fungating lesion, or if it's involving the growth plates, for example, in those cases, those are relative contraindications for limb salvage surgery. Now, can you tell me, okay, so can you tell me the why we give neoadjuvant chemotherapy? What's the advantage of doing that?
The advantage of giving neoadjuvant chemotherapy is that it will cause calcification. There will be a rim of calcification around the tumor, so the surgery will become easy. And second thing is we'll buy out time for the making of the prosthesis. And by neoadjuvant chemotherapy, we can save the limb also. The limb salvage surgery can be easily done.
Yeah, so you're taking care of micrometastasis, you're getting time to prepare the processes. You're, like you said, you get a rim of ossification, which makes the plane of resection easier for limb salvage surgery, right? And also, yeah, it is better tolerated as well. Okay, so all of that. Uh, so what is the ideal necrosis percentage you should get on the surgical specimen?
It should be more than 90%.
Yeah, so below 90% has a poorer prognosis. Okay. So if you don't get 90%, do you switch to another regimen?
No, boss, we'll continue the same regimen, irrespective of necrosis percentage.
Yeah, so that's based on the Uramos trial, right? Yeah, unless there's progression. Okay, I think that's about it. The rest of them we have covered in that other X-ray film that we had over here. Okay, now moving to the next question. Dr. Sriram.
Yes, boss.
Ah, yes.
Uh,
So, what can you describe what you see here?
so this is a gross section of a tumor after of a tumor in the liver, which is showing areas of necrosis, and it is showing areas of necrosis which is yellow in yellowish, which has a yellowish hue.
Okay, so what could it probably be? Assume this is a 50-year-old patient.
Uh, Possibly hepatocellular carcinoma.
Yeah, so most commonly it's looking like a hepatocellular carcinoma. Okay, so I want to ask you,
Yes, ma'am.
what is BCLC?
This is it's Barcelona Clinic liver classification. Basically, it is parameters which we use to decide the treatment plan of HCCs.
Yeah, so what are the three parameters used?
So mainly we look at the PS of the patient. We look at the underlying liver and the nodules, whether they are like means multinodular or if there is a single lesion or not.
Yeah, so we look at the stage, right? We look at the ECOG performance status, and we also look at the Child-Pugh score. Okay,
Child
so those
score,
three are
yes.
taken into consideration. Okay, in what are the criteria you need to meet for to do a surgical resection?
Patient has to be in child A with a single tumor of at least 5 centimeter in size, or means multiple tumors means at least three tumors of maximum being 3 centimeters in size with an underlying normal liver.
Okay, okay, fine. Right. Okay, so those are the two criteria. So basically, your BCLC very early stage, BCLC 0 and BCLC A, right?
Yes, sir.
So if in that scenario, you can consider resection. Okay. Now, for how much of the normal liver should be, as the future liver remnant, how much should be there
FL,
in a
uh,
cirrhotic and a non-cirrhotic?
FLR is like 40% in a cirrhotic and 30% in a non-cirrhotic.
Yeah, so you're right. So that's the cutoff for non-cirrhotic and cirrhotic. Okay. Okay. Now, can you tell me what is bridge therapy and what is downstaging therapy?
Bridge therapy, sir, we are looking
In the
at
context of
basic.
HCC, what is bridge and downstaging therapy?
Yes, sir. Bridge therapy means we are planning a transplant. So in between, we are looking at a therapy just to buy time for transplant. So in that sense, we can do a TACE or tear. Downstaging therapy is something we do. We are looking at resection. So we are initially we can give means therapy to just decrease the size of the tumor.
So you're right. Bridge therapy is local therapy that is given while you're awaiting your liver transplant, right? So local therapies like TACE, transarterial radionuclide therapy, all that is given, right? SBRT can also be given as bridge therapy. So all those are bridge therapies. Downstaging is also in liver transplant context, actually. Okay, so
Oh,
it's done when the patient is borderline meeting the criteria for liver transplant. There we can do downstaging therapy once again with local therapies like TARE, TACE, and SBRT. Okay,
yes, sir.
both in the context of liver transplant. What is the
Oh.
Millian criteria and UCSF criteria for liver transplant?
So that is the extended criteria wherein
So
they
first,
use
tell me Millen.
Milan criteria. I think 7 centimeter.
Yeah, so
Or-
Millen criteria, I'll just quickly say it since
Yes,
we
sir.
have a lot to discuss. So
Yes,
single
yes, yes.
tumor less than 5 centimeter or three or fewer tumors. Okay, less than
Yes.
3 centimeters each. So single tumor less than 5 centimeters or three or fewer tumors less than or equal to 3 centimeters each. That is Milan criteria. Now the extended criteria is the UCSF criteria. This is single tumor less than 6.5 centimeters or three or fewer tumors less than or equal to 4.5 centimeters each. Okay,
Yes.
so that is the UCSF criteria. Now, can you tell me, you have many local therapies. Uh, in what scenarios can transarterial radionuclide therapy and SBRT used where TACE cannot be used?
Uh, so BCLC B in intermediate risk TACE only can be used. TAR and SBRT
Nothing
usually
like
we
that.
don't.
You can use all local therapies in intermediate risk. The answer is portal vein
And
thrombosis. Okay,
okay.
portal vein
Okay.
thrombosis. So portal vein thrombosis, TACE is contraindicated, especially if large vessel, the large branches are involved, whereas TARE and SBRT can still be done. Okay. Tell me in stage 4, um, unresectable HCC or
Yeah.
metastatic HCC, what is BCLC group C?
That is in a normal liver, like LFT will be normal with means
Is it
patient
LFT?
has.
You say CPS score is A or B, and
Uh,
ECOG performance is 1 or 2 with what do you call it? Presence of either nodal involvement, portal vein involvement, or distant
or
metastasis. Okay.
distant meta.
So in that scenario, what are the 3 upfront regimens currently standard of care? The 3 regimens.
3 regimens are atezolizumab, bevacizumab. You can give the stride regimen, durvalumab, tremelimumab, and now recently the checkmate 9DW, that is Nivo EP, has been approved.
Yeah. Can you tell me what is full form of stride and the dosage?
Stride full form
Okay,
was exact.
I'll just quickly. So it's single tremelimumab, regular interval durvalumab. Okay, so you give
Regular
upfront
interval.
300 mg of tremelimumab, which is a CTLA-4 inhibitor, and then you continue with durvalumab. Okay, so that is stride regimen.
Yes, sir.
Okay, so we'll move on to the next one. Yeah, Dr. Poonam, are you there?
Yes, boss.
Okay, yeah. So can you tell me what we see over here?
This is a gross specimen showing kidney section with a tumor in the upper pole of kidney.
Yeah, so this looks like what
RCC.
surgical specimen is it?
Boss?
What sort of specimen is it? Which procedure?
RCC.
It's a post radical nephrectomy specimen.
Post-radical nephrectomy specimen showing a tumor in the upper pole of the kidney.
Okay. So can you tell me in what sort of tumors is radical nephrectomy indicated?
Clear cell.
Yeah. So
If the size.
okay.
If it is extensive and the size is more than.
So I'll just quickly
No,
mention
boss.
it. Radical nephrectomy you do when you have tumors greater than 10 centimeters, if there's a tumor thrombus, if there's lymph node involvement, or if there's locally advanced along with involvement of the adrenals. Okay, in all those settings, you do radical nephrectomy, or if there's high tumor complexity. Okay. So like where all do you do a partial nephrectomy?
A small size tumor.
What is small size?
7 centimeters.
Yeah. So I'll just say it, ideally less than 7 centimeters, only moderate to high complexity, or if you have a solitary kidney, or if you have multiple small bilateral tumors, or if there's a high risk for CKD. Okay. So if the GFR is expected to be less than 45 ml per minute, there you can consider doing a partial nephrectomy. Okay. Can you tell me in a non-metastatic RCC case, what are the conditions in which so what are the other local therapies you can do apart from surgery? Do you know are you aware of it?
Thermal ablation.
So yeah, so basically you'll do radio frequency ablation, microwave ablation. You can also do SBRT. Okay, so these are the local therapies that are given. Okay, so now moving on. Post nephrectomy, is there any role for adjuvant systemic therapy? What are the approved agents?
Yeah, there are some criteria for adjuvant, if it is rhabdoid or
So tell me,
sarcoidoid
tell me the agent
histology.
and the trial and what is the criteria in that particular trial.
Okay. Adjuvant pembrolizumab in keynote 864 564.
Yeah, 564.
Yeah, adjuvant pembrolizumab to be given for 17 cycles if it is low risk IMDC score, and if it is high risk, we can.
Okay, so IMDC is done in metastatic setting. Okay, so you should know the difference. Post nephrectomy, when you're giving adjuvant treatment, you give it if you have, as per keynote 564, you give 1 year of pembrolizumab if you have intermediate high risk. So that is PT2 or PT3 with WHO grade 4 or sarcomatoid features. Okay, so for T2 and so You have intermediate high risk, which is PT2 with WHO grade 4 or sarcomatoid features. So only T2 with WHO grade 4 sarcomatoid features, and also in PT3, and also in high risk features, right? Like PT4 plus or minus involvement of nodes. And in case of metastatic disease, that is amenable to radical resection. Okay, so if you have a single oligometastatic disease, post resection of all the metastatic sites and radical nephrectomy, you can also give adjuvant pembrolizumab. So hope you got PT2 with a WHO grade 4 sarcomatoid features, T3 all cases, PT4 all cases if node is positive, or post metastatic oligometastatic disease with resection or local treatment of all sites. So there you give adjuvant pembrolizumab. Okay. Okay, so okay, moving on. Can you tell me what are the components of the IMDC criteria?
IMDC criteria, the time of diagnosis to the no time of symptom onset to the diagnosis, which is more than 1 year. Platelet
So it's
count.
less than 1 year from time of diagnosis to systemic therapy. Okay. Diagnosis to systemic therapy, less than 1 year. Go on.
Then platelet count, and it should be less than 1 lakh.
So
And
it's raised. Okay. So you should be very specific when you answer this. So IMDC criteria, you have less than 1 year from time of diagnosis to systemic therapy, KPS score less than 80, hemoglobin
KPS,
less than lower limit, calcium less than upper limit,
neutrophil,
and neutrophil count greater
neutrophil
than upper limit, and platelet greater than upper limit.
greater
Okay.
than upper
So
limit.
platelet and neutrophil is raised, calcium is raised, hemoglobin is lowered, KPS less than 80, and less than 1 year from time of diagnosis to systemic therapy. Okay. So so if you have a score of 1 or 2, it's intermediate risk. If you have a score of 3 or more, it
More
is
than
poor
three,
risk.
four.
Okay. Okay. So can you tell me some upfront combination therapies you give in, metastatic RCC?
Metastatic, yes, was there's a clear trial, um, and keynote.
Yeah, just tell me the therapies. I didn't ask for the trials.
Okay, pembrolizumab with lenvatinib, and pembrolizumab with axitinib, and nivolumab with cabozantinib,
And one more?
and
Nivolumab plus ipilimumab. Okay.
nivo-ipi.
Okay. What is the role of active surveillance in metastatic RCC? If you don't know, do you know the answer? Not so. I'll just listen. All these points are important. So active surveillance you do in metastatic setting. If you have, first of all, it should be clear cell. It should be favorable risk. Okay. The patient should be largely asymptomatic. There should be limited disease burden, and there should be no disease in close proximity to any vital organs. So if all those criteria are met, right, and if it's favorable risk and clear cell, then you can consider active surveillance with imaging. Okay. Okay. I hope you got that. Okay, good. Okay, let's move on to the next one. Do we have Dr. Karamveer today?
Sir.
Yeah, can you tell me what we're seeing here?
Sir, this is uterine specimen, sir.
Okay.
In which the uterine cavity is filled with some
Yeah, basically it's a mass in the uterine cavity. It's a cross section of the uterine cavity, post-surgical, and there's a mass in the uterine cavity, right? Okay. So so can you tell me what is the surgery for endometrial cancer?
Sir,
can you describe the surgery?
It is, sir, it is like comprehensive staging in which we preferably do open abdominal hysterectomy, sir, along with the bilateral salpingoophorectomy and sentinel lymph node biopsy, if early stage.
Yeah, so good. So you do a simple hysterectomy, bilateral salpingoophorectomy. You also do a peritoneal cytology, and you do a regional lymph node assessment. The current standard of care with regional lymph node assessment is sentinel lymph node biopsy. Okay. Why do we do a salpingoophorectomy?
Sir, it is hormonal dependent, sir, and for comprehensive staging.
Yeah, basically there's a 8 to 10% risk of adnexal involvement in uterine malignancies. Okay. That's how we do it. Okay, now moving on. Okay, what are the molecular subtypes of C. endometrium?
Molecular subtypes are, first of all, it may be pol mutated.
Okay.
Then, sir, P50, then deficient MMR or proficient MMR. Then P53 wild type mutated. Then, sir, NSMP. And
Okay.
NSMP is further divided in based on hormonal status, sir. It is ER positive or ER negative and high grade, low grade.
Okay, good. Okay, those are the 4 subgroups that we have, right? What is the okay? So what is the PORTEC 3 protocol?
Sir, POTEC 3 was for high risk endometrial cancers.
Yeah, can you tell me the protocol?
Sir, if a patient is of high risk, then it was CTRT was advisor.
A 4 seconds chemo followed
Okay,
by
so basically, if you have, high risk disease, right? That is stage 3 disease, or if you have higher risk histologies, or if you have a P53 mutation, which makes it high risk automatically, uh, right? So in all those settings, you give adjuvant CTRT, that is, you give radiation um, along with cisplatin. Cisplatin was given 50 milligram per meter square. 2 cycles only were given actually. Okay, in that POTEC protocol, although practically speaking, we give weekly cisplatin as well, along with radiation. Following that, you give adjuvant carboplatin and paclitaxel, carboplatin AUC 5, paclitaxel 175 milligram per meter square, and you give 4 cycles of that. Okay, so CTRT with concurrent platinum, along followed by adjuvant carboplatin for 4 cycles. Okay, in high risk disease. Okay, can you tell me in the metastatic setting, upfront setting, right? What are the regimens that are currently approved, the standard of care currently?
Sir, we will divide based on PDL1 status. If it is based on deficient MMR,
Okay.
if proficient MMR, then we can use pembrolizumab plus lanreotide. If it is deficient MMR, then we can use Ruby trial.
Okay, so I'll clarify. Okay, so this pembro and lenva is used in second line setting. Okay, not in first line setting. That is used in, you're right, proficient MMR, but that is in second line setting. So you have 4 immune checkpoint inhibitor combinations that are given. Okay. So based on Rubita, you have dostarlimab plus carbopacli for 6 cycles, followed by dostarlimab maintenance for 3 years. So that is given approved in both deficient MMR and proficient MMR. Okay. Then pembrolizumab you have based on the NRG trial. So that is carboplatin pembrolizumab 6 cycles, followed by pembro maintenance up to 2 years. So that is also approved in deficient and proficient MMR. Durvalumab, on the other hand, is based on DOE trial. That is in carboplatin plus durvalumab 6 cycles, followed by durvalumab maintenance till progression in this setting. That is approved only in deficient MMR. Okay. So it's not approved in proficient MMR. Then you have got atezolizumab based on the ATTEND trial. That is carboplatin atezolizumab followed by atezolizumab maintenance till progression once again. That is also only approved in proficient MMR. Sorry, deficient MMR. So deficient MMR approved only approved in deficient MMR is atezolizumab and durvalumab, whereas dostarlimab and pembrolizumab chemo combinations approved in deficient as well as proficient. So I hope you got the difference there. Okay.
Yes.
Okay, can someone tell me what this is? Okay, Dr. Raja. Can you tell me what this is?
This is a large surgical specimen showing Whipple surgical. I don't know.
Yeah, you're right. It is a post-Whipple specimen. Okay. You can see the intestine, you can see the gallbladder, you can see the pancreas, right? So all those structures can be seen. Okay. So can you tell me in a Whipple's procedure, right?
Yeah.
In a Whipple's procedure, what all do we remove?
In Whipple's procedure, we remove the pancreas. Not
Yeah.
sure.
Yeah. So basically, you right. So you remove the duodenum, the proximal jejunum, the pancreatic head and neck, and the uncinate process, and the gallbladder and the common bile duct. Okay. And the pylorus of the stomach may or may not be removed depending on whether it's a pylorus preserving procedure or not. Okay. In what all cancers do we do, this Whipple surgery?
Uh, Pancreas, then
Head of pancreas,
cholangiocarcinoma.
cholangiocarcinoma, good.
Mm,
What is there around the head of the pancreas?
Duodenum.
Duodenum. And what is connecting the duodenum and pancreas?
The
Ampulla of Vater, okay.
ampulla of Vater, yeah.
Yeah, so head of pancreas, duodenum, common bile duct, and ampulla of Vater, all these cases you tend to do a Whipple surgery. Okay. So can you tell me, in a resected case of CA pancreas, what are the current adjuvant options that we have?
In resected CA pancreas, we can, based on the staging, and based on staging, we can put the patient on single agent gemcitabine and adjuvant gemcitabine with nab-paclitaxel.
And?
Right?
And if it is intestinal type of variant, we can also give Folfox.
Yeah, so basically, for a CA pancreas, right? Current standard of care is modified FOLFIRINOX in the adjuvant setting. Okay. You also have gemcitabine plus capecitabine, and gem-nab-paclitaxel is also there. So those three are the preferred ones. Single agent gemcitabine you only give if the patient is not tolerating chemotherapy. Okay. So it's not fit for chemotherapy. Multiple agents. Okay. So in the metastatic setting, what are the regimens that are preferred in a fit patient?
So if the patient is fit, we will give modified FOLFIRINOX or NALIRIFOX.
Okay.
Gemcitabine, nab-paclitaxel.
Okay.
And
yeah, you're right.
Yes,
so these
I
three
remember.
regimens are the standard three regimens that you give in the metastatic setting. Okay. Okay, good. Okay, so Dr. Salahuddin, are you there?
Yes, sir, I'm there.
Yeah, can you tell me what this is?
Sir, we can see a specimen of liver, a gross specimen of liver.
Is this the liver or something?
Oh, sorry. A gross specimen of lung.
Okay, so this looks like a pneumonectomy specimen, right? Okay,
yes,
so can you tell me, sorry. So can you tell me, along with in early lung cancer, along with surgery, can you tell me the quantum of benefit given by chemotherapy? 5-year OS benefit, absolute benefit given by giving adjuvant chemotherapy.
5 to 10%.
Yeah, so it is 5%. Okay, based on the LACE meta-analysis, it is 5%. Okay.
Okay.
So in a case of right. So currently we have moved on to the era of immune checkpoint inhibitors. Okay. Can you tell me the approved perioperative ICI regimens and the approved neoadjuvant ICI regimens and the approved adjuvant ICI regimens?
So the currently approved peri-op regimens include giving pembrolizumab in the neoadjuvant setting along with the chemotherapy, they're followed by surgery, which is again followed by pembrolizumab. Other than that, we can use durvalumab.
So that's Keynote 671, right? Keynote 671. Okay,
yes,
go on.
Other than that, we can use atezolizumab, which is in the setting of adjuvant only. We can give only adjuvant.
I'll just quickly classify this. Okay. So you need to say it in an organized manner. So start off with adjuvant setting. There's adjuvant atezolizumab, right, based on the IM Power trial, and there's also adjuvant pembrolizumab based on the PEARLS trial. Okay, both are given for 1 year. That is shown. Both have shown DFS benefit. Then in neoadjuvant only setting, you have based on the Checkmate 816 trial, you have chemotherapy plus nivolumab given 3 weekly for 3 cycles prior to surgery. That has shown a DFS and OS benefit. And in the perioperative setting, you have 4 trials. So you have the Keynote 671 trial, which is based on, you give neoadjuvant chemo immunotherapy with pembrolizumab, surgery, then adjuvant pembrolizumab. That has shown DFS and OS benefit. And then you have the AGN trial as well as the Checkmate 77T trial. So AGN trials for durvalumab perioperative, Checkmate 77T is for nivolumab perioperative, and you also have the rational trial, which is for toripalimab. Okay, so those are your four perioperative trials. Out of all
Yes.
these trials, only the perioperative pembrolizumab and neoadjuvant only nivolumab have shown OS benefit currently. The others, the data is still maturing. Okay. Okay,
Yes.
so keeping that in mind, before before doing before starting the patient on immune checkpoint inhibitors, is there something else you would like to do?
So we have to look for any driver mutation which is present. We have to look for that, because in that case the treatment will be driven, the pathogenicity is driven by the driver mutation. You have to target that rather than the
So
chemo.
what are the two driver mutations that we are looking for, and whether
So
there's evidence for giving treatment?
two most common are EGFR mutation and ALK mutation, sir.
Yeah, so it is approved only adjuvant, post surgery adjuvant, targeted therapy for a driver mutation is approved only for EGFR and ALK. So if EGFR and
Yes.
ALK is present on NGS, then only you omit ICI. Okay, the other ones we still give ICI actually. So
Yes, sir.
EGFR, you have adjuvant osimertinib for 3 years based on Adora trial, and
Yes, sir.
for ALK you have based on the Alina trial you have alectinib for 2 years. Okay.
Yes, sir.
Okay, so can you tell me, for an unresectable but non-metastatic lung cancer case, what is the standard treatment of care?
So the standard of care in case of unresectable stage 3 lung cancer is that we have to start the patient on concurrent chemo and RT. The chemotherapy generally is paclitaxel carboplatin or carboplatin, etoposide carboplatin, and which is given after the chemotherapy concurrent CT-RT. The patient has to be taken up for 1 year of durvalumab as per the sorry, I forgot the name of the trial.
Pacific trial. Okay, so is there any case where you won't give durvalumab?
Sir, if the patient is EGFR mutated, we can also give osimertinib.
Till how much time do we give it?
3 years.
Limitless.
So I'll tell you that scenario. So the answer is you give concurrent CT-RT. If it is squamous cell, you can give concurrent cisplatin and gemcitabine. Or if it is adenocarcinoma, you usually give cisplatin and pemetrexed. Okay. So you give with 60 gray 30 fractions of radiation along with concurrent chemotherapy. Following that, you give adjuvant durvalumab for 1 year. If the patient is EGFR mutated, currently based on the LAURA trial, it is adjuvant osimertinib, and that is given till progression actually. Okay. Okay, let's move on. Okay, Dr. Sriram.
Yes, sir.
Yeah, please tell me what this is.
So this is a gross specimen of the testis with the spermatic cord.
Okay.
There is a tumor in the means with a yellowish color, which is occupying the left testis.
Okay, so basically we don't know whether it is we do not know whether it is, so this you should say this is a high inguinal orchidectomy specimen. We don't know the site. This is actually a cross section of a single testis. Okay, so it's a high inguinal orchidectomy specimen for a testicular tumor. Okay.
Yes, sir.
So can you tell me why we do high inguinal orchidectomy rather than doing simple orchidectomy?
Basically the spermatic cord is can be involved in means majority of the cases. So and tumor may also later recur in the spermatic cord. So cord also should be removed.
Okay, that's one reason. Can you tell me something else?
Yeah,
I'll just complete it. You don't need you don't want to cause tumor spillage while removing the testis, so you remove it along with the spermatic cord to obtain negative margins, especially the spermatic cord is involved, right? So that's why you remove the sperm. And also the testis is a sanctuary site, so chemotherapy might not be that it might not be able to penetrate, right? Okay, so yeah, can you tell me the treatment for non-seminoma, good risk, intermediate, and adverse risk? Can you tell me the treatment of choice?
So for good risk non-seminoma, like we give, sir, we can give means either we can do an RPLND or we can give means 3 cycles of BEP or 4 cycles of EP.
Okay, so R-pilinity is not in the answer. That is only for a very that's not what you should answer in the exam. R-pilinity you use when it's only N1 disease. Okay, that is only
Okay.
you need not mention that. So you can just say 4 cycles of BP or three. Sorry, 3 cycles of BP or 4 cycles of EP. Okay, and for
Yes, sir.
intermediate and poor risk,
Intermediate of poor risk will give like 4 cycles of EP.
BP.
BP.
So okay, so good risk 3 cycles of BP or 4 cycles of EP. Intermediate and poor risk 4 cycles of BP. Okay.
BP. Yes. Yes.
Um, Okay, when you post giving chemotherapy in a seminoma, now we're talking about seminoma.
Yes, sir.
When should we post chemotherapy? When should we look at the tumor markers?
Post chemotherapy, like 4 to 6 weeks.
Yeah, so 6 weeks is the cutoff. You look at the tumor markers, and then what do we do to evaluate for the residual disease?
So initially we do a CT. If there is a residual disease like more than 3 centimeter, then we ask for a PET scan.
Okay, suppose you did a PET CT and
Yes,
you
sir.
have uptake, then what do you do?
Then if it is more than 3 centimeter and there is an uptake, we ask for excision, and then post which we give we check for the tumor markers, and then we give two
We
more
already checked
cycles
for
of
tumor markers. Why do you check
yeah,
again?
yeah. So we give 2 more cycles of chemo.
What chemo do you give in that setting? If there's residual disease in the completely excised tumor.
So EP 2 more cycles.
Yeah, that is fine. Okay, what if you're not able to completely excise the tumor, the residual disease? That
Then
is
we'll
as
treat it
uptake on
like
PET CT.
with second line chemo, like whether
Yeah, so
TIP
you
or
give second line chemotherapy. Good.
yes.
Okay. Now, moving on. Right, I think that is enough. So they can ask you anything in this sort of the specimen. So, if you ask the testicular tumors case presentation, we have covered everything that can possibly be asked. Okay. Um, yeah, Dr. Raja, can you tell me what this is? So start assuming that this is from chromosome 1 and this is chromosome 24, okay? So this is a 40-year-old who presents with abdominal pain and early satiety. And this is the conventional site of it.
5, 6, 7, 8, 9. So there is a translocation. If I count chromosome number 1, 2, 3, 4, 9, and the translocation has happened with the chromosome number 22. So it's a translocation 922 consistent with BCR ABL translocation as we see in chronic myeloid leukemia.
Yeah. So can you tell me what translocates to what?
So the ABL gene on chromosome 9 translocates to the BCR on chromosome 22, which leads to formation of BCR ABL transcript on chromosome 22, which is the
Very good.
Philadelphia chromosome.
Yeah, that's what we're looking for. Okay, so can you tell me how will you decide first line treatment for CML?
After all the investigation and making the diagnosis and getting the BCR ABL transcript baseline, then I will do a SOCAL scoring to see whether it's a low risk or a high risk. If it's a low risk, I'll start with I will start with first generation TKIs. If it's a high score, I'll try to get I will want to get more deep molecular response. I'll start with second or third generation second generation TKIs.
Okay.
Not
What
third.
else do you look at?
Currently,
Currently with latest advances, we look at whether the patient is a candidate for TFR, right? Treatment-free remission.
treatment-free remission, yeah.
So what are the candidates that we usually consider for treatment-free remission and what do we give there?
So if a patient is compliant and can undergo PCR and can undergo this MRD testing through a standard laboratory every monthly, then we can consider and is fit to take second generation TKIs, then we can consider him for treatment-free remission, and we'll start with drugs which give us more deep molecular response like nilotinib.
Yeah, so
second
use
generation.
second generation TKIs for TFR. And so when you ask for treatment, first you look at whether the patient needs TFR, usually in the patient planning for pregnancy or a very young patient, okay, where you're planning to discontinue drugs. Second thing you look at is the SOCAL or ELTS score. In the TK era, we rely on the ELTS score. Okay, SOCAL was for interferon era. And third thing is you look at the comorbidity. So these are the three criteria you look at. If it is high risk or if the patient is planning for TFR, then you give second generation TKI because we need a deeper molecular response. Okay, conditions now, criteria for TFR is, I've mentioned it in yesterday's video. Basically, you should have, so basically it's a patient who, has a normal transcript, that is P210 transcript, is in CML-CP, has a rapid turnover, has access to rapid turnover PCR, will be compliant to do PCR monthly, has used the first generation TK for 5 years or second generation for 4 years,
5 years, 4
and has
years.
attained MR4 for 3 years or MR4.5 for at least 2 years. Okay. So all these criteria met, you do TFR. Okay. Now moving on, if the patient has pulmonary hypertension, which TK can cause pulmonary hypertension?
Dasatinib can cause pulmonary hypertension.
Which one can cause pancreatitis?
Nilotinib can cause metabolic syndrome and pancreatitis.
Okay. Which is a cardiac safe TK?
Which is what, boss? Sorry.
Cardiac safe TK.
Bosutinib.
Yeah, bosutinib. Okay. Bosutinib is a cardiac safe TK. Okay. Now, okay, good. Okay, so moving on. Yeah. Dr. Karamveer,
Yes, sir.
can you tell me which of these pure tone audiometry graphs shows sensorineural hearing loss? If you're not sure, it's okay. I'll just say the answer.
Third one, hopefully.
So it's the middle one. Okay. So in sensorineural hearing loss, there won't be a difference between the air conduction and the bone conduction. Okay. So basically, both faculties are completely are compromised. So the graph won't have any separation between air conduction and bone conduction. If you can see over here in that middle graph, it is like that. Okay. In case of conduction hearing loss, you'll have presence of bone conduction, which you can see over here. It is not compromised in the first graph, but air conduction is affected. Okay. So bone conduction is there, but air conduction is affected. So it's below. Whereas in sentinel, both are affected and there's less than 10 decibel gap between both the curves. So that is how to detect sentinel. Okay. Yeah. So can everyone mute their, just please? Okay. So in sentinel here, which drug do we test for this?
Cisplatin, sir.
Yeah, cisplatin. Okay. So can you tell me what the Galsky criteria is?
Sir, EGFR should be more than 60. The NYHA grade should be less than equal to 2. The NYHA EGFR, sir, and
yeah, so Galsy criteria is ineligibility for cisplatin. Number one is, of course, the EGFR if it's less than 60. If you have an ECOG performance score of 2 or more, if you have peripheral neuropathy or sensorineural hearing loss that is grade 2 or more, or if you have NYHA, grade 3 or more. Okay, so that is the Galsky criteria. So that's what we use. Okay, so can you tell me what the JEP regimen is? JEB, GEB regimen is. So if you're not sure, I'll tell you it is carboplatin, etoposide, and bleomycin is given for GCTs in children because in less than 10 years of age, there is high chance for ototoxicity. Okay, ototoxicity occurs when the inner ear, outer hair cells are affected, and usually the higher frequencies are affected first. Okay, and usually it is irreversible.
Okay, sir.
Yeah. So, Dr. Sriram, can you tell me what we are looking at here?
Yes, sir. So it's a flow cytometric curve, which shows CD 19, 20, and 103. So it's, I think it's hairy cell leukemia.
Yeah. So if you look here, I'll just point it out. So this means it's both markers are negative. This means that both markers are positive. Okay. And this means that this x-axis marker is positive, and this is where y-axis marker is positive. So here you can see that it is CD19 positive, CD10 negative. Here you can see that it is CD20 positive, but CD5 negative, right? Here you can see that it is both CD25 and CD103 positive, right? And right. So based on all these, you can say that something that is CD19, 20 positive, CD5 and CD10 negative, but CD103 and CD25 positive, it is mostly looking like hairy cell leukemia. Okay.
Yes.
So can you tell me what the first line treatment for hairy cell leukemia will be?
So cladribine, single agent
Dose?
cladribine.
And
I
how we
think
administer?
It's given IV 0.3 mg per meter squared, I think, sir. Day 1 to day 5.
It is 0.1 milligram per kg.
0.1.
And it is given at a at 24 hours for 7 days. Okay, 0.1 milligram per kg per day for given as a 24-hour infusion for 7 days. So that's how we give it. Now, another thing to note here is that you can also give it as 0.15 milligram per kg as a 2-hour infusion for 5 days. So those are the two ways we'll give it. So when you're giving cladribine, what all do you need to be aware? What all precautions should you take?
Basically, cladribine it causes delayed neutropenia, so like count monitoring should be advised. Like means post to after 1 week
Okay, I
only.
got that point. Next.
Then there is chances of infection, so prophylaxis should be given.
Okay, what sort of immunosuppression does it cause?
Uh,
Okay, so I'll finish that off. So basically, when you're giving cladribine, there's a high chance for infections. It causes T cell immunity is affected, and that is affected for around 6 to 12 months after giving cladribine. So give your prophylaxis, asciversis scan, even antibiotics when required, right? So that is number one. You should delayed myelosuppression is there. Immunosuppression is up till 12 months. Myelosuppression is up till 4 to 6 weeks. So count monitoring is required. And also you should give irradiated blood products because there is a chance for transfusion associated GVHD. Okay, after giving this cladribine. And one more thing to note, they commonly ask in the exam is when will you reassess post cladribine? So you reassess. So you treat first of all if you have indications. If there's any cytopenias, there's symptomatic splenomegaly lymphadenopathy. Otherwise, you just follow up the patient, right? And once you have treated, you evaluate only at 3 to 6 months with the bone marrow. Okay, you don't evaluate immediately. You evaluate after 3 to 6 months. So that is another thing that you need to know when it comes to hairy cell leukemia. Okay, so Dr. Poonam, what do we see here?
This is a electrophoresis serum protein electrophoresis curve showing gamma light chain peak, which is and the below one is a immunofixation assay where we are seeing a kappa light chain
Restriction.
restriction.
Yeah, so basically you have what is looking like a serum, protein electrophoresis and serum immunofixation, right? So the upper one is protein electrophoresis. You're seeing an M band here in the gamma region. So there's a monoclonal gammopathy that is there. Next, you're looking at immunofixation to see what chains are affected. So it is IgG, as you can see here, and as well as the kappa gene. Okay, so it's looking like an IgG monoclonal gammopathy. Next, you need to apply the Sinclair criteria, do other workup to confirm that it is myeloma. We have discussed that yesterday, so go back to the previous video. So I won't discuss any further because I think we have discussed myeloma in depth yesterday, right?
Okay.
Okay, Dr. Raja? Dr. Raja, are you there?
Yes, boss.
Yeah, okay, so I'll give you a case scenario, okay? So you've got a Burkitt's lymphoma, and we have started the patient on, what R-Codox M. Okay. The resident
boss.
forgot to write anti-TLS prophylaxis. And you get this. What are we seeing here?
I'm not very good with ECGs, boss, but in the lead 2, I can see that
Look at the T
there
waves.
is
I'll
T
give
segment.
you a...
There's T segment elevation and also a bit of ST elevation, consistent with maybe if it's a T elevation, hyperkalemia, I'll suspect, since you told it's a TLS.
Yeah, so Burkitt's lymphoma, they'll give you something like that, some sort of scenario like that. So Burkitt's lymphoma, hyperacute T waves, hyperkalemia, TLS, right? So can you tell me what are the lab parameters you'll expect in a TLS?
In TLS, we have the Cairo Bishop criteria, in which we'll see 4 laboratory values, like if the potassium is more than 6 milliequivalent per liter, or if it has increased by more than 25% of the baseline. If serum calcium is less than 7 milligram per deciliter or decreased by less than 25%. If phosphate more than 4.5 mg per deciliter or increased by 25%. And last Okay, so
Uric acid.
yeah, sorry, uric acid more than 8 or increased by more than 25%.
Okay, so that is the lab criteria as per Bishop Cairo. What is the clinical criteria?
In clinical criteria, just a second, I'm getting in clinical criteria, we have the lab criteria plus if there is increase of creatinine more than 1.5 times of the upper limit, if there is seizure, if there is any cardiac dysfunction or death.
Okay, good. So yeah, so lab criteria plus one of the clinical criteria, you can diagnose TLS, right? So can you tell me some conditions, malignancies or scenarios where you have high risk of TLS? Just
In
name three or
majorly
four.
in the hematological neoplasm like AML, Burkitt lymphoma, primary mediastinal B-cell lymphoma, DLBCL,
Yeah, so you have mentioned the lymphomas. I'll just tell you the
germ cell
scenarios.
tumors.
Okay. So to be more specific, you have ALL that is count of greater than 1 lakh on presentation. Okay. Or AML greater than count of 1 lakh. Then you have all Burkitt's leukemia. Okay. So all Burkitt's lymphoma, there is a chance for TLS. And if you have these other aggressive NHLs, that is basically if you have a lymphoblastic lymphoma, so all lymphoblastic lymphomas, advanced lymphoblastic lymphoma and Burkitt's lymphoma, there's high chance for TLS, ALL and AML with a count of greater than 1 lakh. And when you come to DLBCL, advanced DLBCL with LDH greater than 2. Okay. So all advanced LPL, Burkitt's lymphoma, DLBCL stage, advanced DLBCL, but with LDH of 2 or more, 2 times or more of that of the upper limit, and AML and ALL with 1 lakh or more count. Okay. So there you have a 5% and more risk of TLS. Okay. So in a high risk case of TLS, what will you do?
In a high risk case of TLS, I'll ensure that there is adequate urine output. I will hydrate the patient. And since it is a high risk, I'll give resburicase injection also.
Okay. So anything
And
else?
continue monitoring.
So you'll give Febujet or allopurinol. Along with that, you'll also add rasburicase, and you'll give
Resburicase.
hydration, and you'll also monitor. You should go do
Monitor.
high risk monitoring, right? So the RFT and electrolyte should be monitored constantly, preferably even once or twice a day. Okay.
And,
So
and correct the electrolyte.
yeah. Okay. So rasburicase and Febujet, what is the mechanism of action?
Rasburicase helps to dissolve the uric acid into allantoin, so it gets excreted. Febuxostat is a recombinant xanthine oxidase inhibitor.
Okay. So xanthine oxidase inhibitor is Febuxostat. Febuxostat, and rasburicase is a recombinant uric oxidase. Okay. So it's an enzyme that
Yeah.
breaks down, like you said, to allantoin. Okay. Rasburicase is given in high risk prophylaxis or if there's pre-existing TLS. Whereas in intermediate and intermediate risk, you need not give rasburicase. You can just give your xanthine oxidase inhibitor along with hydration and your this thing monitoring, high risk monitoring. Okay. Okay. Good. Now moving on. Okay. So the patient was started on ribociclib in a case of hormone positive MBC, and the patient developed this ECG. Complaint of palpitations with this ECG. What do you see here? Dr. Sriram, can you tell me?
Boss, this is like a ventricular arrhythmia, possibly due to ribociclib.
So, like we all know, you should know
Mm.
the side effect of ribociclib. It causes QTC prolongation, right?
Yes.
So it is torsades de pointus, right? So it's a polymorphic ventricular arrhythmia that you can see over here. So what are the drugs that cause QTC prolongation? Can you name 3 or 4 drugs? Classes of
Yes, sir. Atra
good.
can cause. Then, even the EGFR TKs, like Jeftinib,
Yeah, mostly
and
osimertinib. Okay.
osimertinib, yes.
Yeah.
And then then there can be the ribociclib can cause. Then crizotinib.
Good. And also your CML TKIs, right? They can also cause QTC prolongation. Okay. So just
Yes.
remember that. What are some of the other drugs, non-oncology drugs that can cause QTC prolongation that we need to check for interactions with?
Okay, well,
So
I'm not.
your antidepressants, antipsychotics, right? Your macrolide antibiotics, etc. All these you need to check because they can also cause QTC prolongation. Okay. Okay. Now we'll move on to the drugs. Now, as you know, the time right now is 6:16. So instead of asking the questions, I will quickly go through these because, otherwise we won't finish this. So when you come to drugs is the most important part of your grand viva. Most examiners, they allow you to select the drug. Okay, so study the common ones very thoroughly. You can't study every drug out there, obviously. Study the common ones very thoroughly. Always mention the mechanism of action, mention the some of the pharmacokinetics if there's any important point there, mention the dose, mention the mode of administration, mention the indications, any special precautions, and following that, the adverse effects. Okay. So I'll just quickly go through these drugs because otherwise we won't finish it today, right? We don't have time for a question and answer format because I'm trying to pack in all the drugs. So methotrexate. When it comes to methotrexate is an antifolate that works in the S phase of the cell cycle, and basically it inhibits the enzyme. It enters the cell, it gets polyglutamated, and following that, it inhibits the enzyme DHFR as well as thymidate synthetase in its polyglutamated form, which leads to deficiency in DNA synthesis. Now, methotrexate is administered through various modes. So usually it is administered in IV form, in IM form, in IT form, uh, and intrathecally as well as oral form. Okay, so all those forms it's administered. It's metabolized in the liver and excreted through the kidneys. Now the three dose ranges of high dose methotrexate. So you have high dose that is greater than 500 milligram per meter square. You give it in CNS lymphoma, osteosarcoma, ALL consolidation, CNS prophylaxis with high CNS IPI, lymphomas, treatment of Burkitt's lymphoma, etc. And in SMILE protocol for NK T cell lymphoma. Intermediate risk is 50 to 500 milligram per meter square. It's given in GTD, and low dose is less than 50 milligram per meter square. It is given in various conditions such as DD-MVAC regimen, in metronomic chemotherapy in head and neck, in ALL as form of maintenance with 6-MP and methotrexate, right? So those are some of the conditions where you give low dose methotrexate. Now, moving on. So let us look at the precautions you need to take, especially with high dose methotrexate. So you need to hydrate the patient. You need to monitor urine pH, make sure it is above 7.5. You need to make sure there are no drug interactions, such as with aspirin, penicillins, NSAIDs, probenecid, with PPIs, with Septran, etc. Right? And avoid folic acid supplements. And you also need to give along with hydration, you should give sodium bicarbonate. Okay, so hydration 2 to 3 liters per minute, 2 to 3 liters per meter square per day. Look for drug interactions. Make sure there's no third place fluids, right? And maintain the urine pH. Make sure the LFT and RFT is normal before giving high dose methotrexate. Okay, so that's the precautions for that. Now, coming to the side effects. So we'll go through the side effects one by one. So you have myelosuppression. It is usually seen with low dose methotrexate. And so before that, I'd like to mention that with high dose methotrexate, you have leucovorin rescue. So leucovorin, it neutralizes this high dose methotrexate and it decreases the toxicity. So so overall, the toxicities of methotrexate include myelosuppression, which is seen with low dose methotrexate, mucositis, once again low dose methotrexate, nausea and vomiting across different doses. Nephrotoxicity is seen usually with high dose methotrexate. Hepatotoxicity is seen usually with low dose methotrexate on long term use. Pulmonary toxicity is once again seen with low dose methotrexate, usually in the form of pneumonitis. Neurotoxicity, CNS toxicity is seen usually with high dose methotrexate. And you have dermatological toxicities, which can be seen with all different types of methotrexate. So that's the toxicities as well as the dose range at which it can be seen. That is very commonly asked. Okay. So can you tell me some, okay, this I'll ask, can Dr. Raja, can you tell me some other colored chemotherapies?
Hello? Yes, boss. Doxorubicin, ruby colored. Then mitomycin C has a bit of bluish hue. And
Xantron.
Yeah, so you have all the rubicins, right? Ruby, red colored. Okay. Then you have methotrexate, which is yellowish in color. You have dacnomycin, which is amber colored. Then you have mitoxantron and mitomycin, which are bluish in color. Okay. So those are some of the common colored chemotherapies, just as they ask you. So now we are coming on to a very important one, which is cisplatin. Okay. So cisplatin is a platinum analog. and if you look at the structure of the drug, it is a diamine dichloroplatinum agent, right? So the diamine forms the carrier group, and basically that is responsible for interaction with the DNA and the mechanism of action, as well as the resistance mechanism. The leaving group is dichloro, which is responsible for the toxicity of the drug. Okay, so given that basically the drug binds to the N7 nitrogen of the guanosine group, and it forms intrastrand adducts by connecting to, so it binds to the N7 position of the guanine group on the DNA molecule and causes intrastrand adduct formation. Okay, and that leads to DNA damage and death. So mainly, if you look at the metabolism is primarily through the kidneys, and it is a biphasic form of elimination that is seen. Cisplatin is always given in IV form, and it is given for a wide range of indications. So I'll just name a few of them. It is given in germ cell tumors as part of the BEP regimen and TIP regimens. It is given in head and neck malignancies, with part of the TPF regimen or the PF regimen. It is also given in osteosarcoma as part of the AIP regimen. It is given in head and neck malignancies as concurrent agent in the form of cisplatin, 100 milligram per meter square, day 1, 43, or weekly cisplatin. It is also given in bladder cancers where you give gemcitabine and cisplatin neoadjuvant followed by surgery, right? So those are some of the indications of cisplatin. Now coming to the precautions you administrate with hydration. Basically, you give NaCl. Um, so usually you give, if it is for any dose that is greater than 75 milligram per meter square, you give 1 liter of NS prior, followed by mannitol, which is given over 30 minutes, followed by cisplatin administered in 2 hours. Following that, you give 1 more liter of NS, and along with that, you can add KCl and magnesium sulfate ampules. Okay. It is also highly antiemetic, so use level 4 anti-emesis. And coming to the toxicities, it can cause nephrotoxicity, nausea and vomiting, myelosuppression, neuropathy, which is usually irreversible. It can cause autotoxicity, which is also irreversible. And rarely, on repeated use, it can cause hypersensitivity. So it's delayed. Usually, you do not re-challenge when there's platinum-based hypersensitivity. It can also cause, it's an irritant at the injection site, and rarely it can also cause thromboembolic phenomena. Okay, so that is cisplatin in a nutshell. So you should say it like this, in a flow. Then the examiner won't ask you anything. Basically, just take a deep breath and go in a flow and keep talking. Okay, and under those subheadings which I mentioned. So now coming to another, big daddy, it is paclitaxel. Okay, so then if you take paclitaxel, you should say it is isolated from the Pacific yew tree. It usually acts in the G2M phase of the cell cycle. G2M phase transition. Basically, it enhances tubulin polymerization, leading to it inhibits the dynamic process of the microtubules by enhancing tubulin polymerization, thereby preventing cell division. Okay, so that is how you give it. Usually, you give it through the IV form. It is, mainly processed by the liver, right? It's got hepatic processing, and it has poor CNS penetration. Okay, so now it is coming to. It also has CYP3A4 inducer and inhibitor interactions. Okay, now coming to the special considerations, so coming to the indications, there are a wide range of indications for paclitaxel. You give it as part of carbopacly in both the in CA ovary, in both the resectable as well as metastatic setting. You give it as part of management of head and neck malignancies, where you can give carbopacly in the metastatic setting. You give it as part of TIP regimen in germ cell tumors. Right. You give it as part of weekly paclitaxel in ovarian malignancies. You give it as part of carbopacly in endometrial carcinomas. Right. You give it as part of carbopacly in CS cervix. So those are some 5 indications. Now the dose of paclitaxel weekly, it is 80 milligram per meter square and 175 milligram per meter square if it's given 3 weekly. Now coming to the special considerations, you need to give pre-medications because there's a high risk for hypersensitivity reactions. So you give it as dexamethasone 20 milligrams 12 and 6 hours before the infusion. Okay, and prior to the infusion, give Avil, Rantac, and also Dexa along with ondansetron, etc. So that is the pre-medication. You also use a codon set 0.2 microns codon to filter out chemophore EL, and also you need to give a non-PVC bottle to prevent leaching of plasticizers. Okay, so that is what we look at. Now, coming to toxicities, it can cause myelosuppression. It is more commonly seen with 24-hour infusion paclitaxel. Right? It can cause hypersensitivity reactions. It can cause neurotoxicity. So peripheral sensory neuropathy is caused, right? It can cause myalgia that is seen in the initial few days. It can cause cardiac rhythm abnormalities, right? It can cause mucositis diarrhea. It can cause alopecia, and it can cause onycholysis or breakage of the nails, and it can also cause ILD. Okay, so those are all the points regarding paclitaxel. Now, coming to the next drug, it's taxotere docetaxel, right? So docetaxel, once again, I won't mention the mechanism of action again. Same mechanism of action as paclitaxel. It is given in the IV form. It is processed usually by the liver, right? It's got hepatic metabolism. So this hepatic dose adjustment. And so basically it is given in breast malignancies in AC followed by taxane. It is also given in the TCH regimen and the TC regimen in CA breast, right? TCHP regimen, there also we get docetaxel, and AC followed by taxane, you get docetaxel, and TC regimen also you give docetaxel. Okay, so in head and neck malignancies, as part of the TPF regimen, you give it. In metastatic prostate cancer, you give single agent in docetaxel. In non-small cell lung cancer, also you can give second line docetaxel post first line progression, right? So those are some of the indications of docetaxel. Now, moving on to the special considerations, you give pre-medication with Dexa 8 mg BD for 3 days because it can cause fluid retention and hypersensitivity. So to prevent that, you give Dexa 8 mg BD for 3 days. So on day 0, on day of chemotherapy, and 1 day after chemotherapy. Okay. Adverse effects include myelosuppression, which is more than paclitaxel, hypersensitivity reactions, fluid retention due to increased capillary permeability, peripheral neuropathy, alopecia, mucositis diarrhea, right? And it can also cause sometimes, very rare, can cause hand-foot syndrome as well. So that's it when it comes to docetaxel. Okay. Now, coming to a very important drug, this is doxorubicin. Okay. So doxorubicin is a topoisomerase inhibitor 2, right? So what it does is topoisomerase 2 inhibitor, it basically acts by breaking up the DNA knots, right? So, or the DNA knots in supercoils, it uncoils that and allows DNA replication to occur. Okay, so topoisomerase 2 inhibitor, it prevents that repair mechanism and causes DNA death. So anthracyclines, it is usually cell cycle non-specific. Um, it inhibits topoisomerase 2. It also intercalates into the DNA and prevents its function. And it also causes reactive oxygen species, which can also cause DNA damage because of its quinine ring. Okay. It's usually given in an IV form. The metabolism is usually hepatic, and the CYP3A4 inducer and inhibitor interactions. Coming to special considerations, it is a strong vesicant, so you should always give it first in any regimen, right? When the IV line is fresh, and you should also know the vesicant management, which consists of cold compress to neutralize the drug, application of DMSO and also dextrosoxine. Okay. So now another consideration is the cardiotoxicity. So always do baseline echo and echo monitoring frequently as per the Schwartz guideline. Okay. So it causes type 1 cardiotoxicity. That's why you do echo monitoring. Now, coming to the indications of doxorubicin, right? So doxorubicin is given mainly in breast cancer as part of AC followed by taxane. It is given as single agent doxorubicin in metastatic breast cancer. It is given as part of as single agent doxorubicin in case of CA ovary, right? It is given as part of initially given as part of the CAP regimen. It is given as part in Wilms tumor, right? As part of the DD4A regimen, where you give vincristine, doxorubicin, and dactomycin. It is given as part in Ewing sarcoma as part of VAC-IE alternating regimen, right? So all those settings you can give doxorubicin, right? Now, the cumulative dose of doxorubicin is 450 milligram per meter square. Now, coming to the toxicities, it can cause myelosuppression, it can cause nausea and vomiting, it can cause mucositis and diarrhea, it can cause cardiotoxicity, which is usually irreversible. It is a strong vesicant. It can cause alopecia and hyperpigmentation of the skin and nails. Also, it can cause secondary malignancies as well. So that's doxorubicin. Now, once again, a super important drug, that is cyclophosphamide. Okay. So coming to cyclophosphamide, basically it is an alkylating agent, right? It is cell cycle non-specific. Basically, it binds to the N7 position of guanine in DNA, and it leads to interstrand linkages, which leads to breakage of DNA, DNA strand break, and cell death. Okay, so it is usually metabolized by the CYP set of enzymes. So CYP3A, 3A4, right? And it basically gets converted to the active form of cyclophosphamide through that, and it is, uh, you know, it is inhibited, or it is it goes into its inactive form with aldehyde ALDH enzyme, right? So basically, cells that have aldehyde dehydrogenase enzyme, they will have less toxicity with cyclophosphamide, such as platelets, which is why you see less thrombocytopenia. That is regarding the metabolism. So now coming to the modes of administration, you can give it oral, you can give it IV as well. Okay, and it is available as a powder, and usually mix it with NS and shake it to dissolve the drug, right? So special considerations involve, it is secreted mainly by the kidneys. So you need, so it is secreted mainly by the kidneys, but there are no dose modifications based on kidney or liver function. That is a special thing here. You should hydrate the patient. You should drink 2 to 3 liters of water per day. You should also add mesna if you're giving a dose of 2000 milligrams of cyclophosphamide or more. So give it at 60% of cyclophosphamide dose. We're giving 2000 milligrams or more of cyclophosphamide. CYP3A4 interactions are there. Now, coming to the indications, you have many, like breast cancer, you give ACEC. Or, in case of, your RMS, where you give VAC, or Wilms tumor, where you also give cyclophosphamide, Ewing sarcoma, where you give alternating VAC IE, gestational trophoblastic neoplasms, where you give IMACO regimen. Right, your right, your in case of your hematological malignancies, such as induction for BFM90, where you give induction phase B, you give cyclophosphamide, RCHOP regimen, ARDA-APOC regimen, R-cordoxim regimen, CyBOT regimen in myeloma. Also used in BMT setting as part of the Bucay conditioning regimen. You can also use in haploidentical transplant, post transplant, to prevent GVHD. Okay, so those are all the conditions in which you can consider using cyclophosphamide. Now, coming to the adverse effects. So there's low dose cyclophosphamide, which is less than 70 milligram per meter square. Intermediate dose, which is 750 to 1500 milligram per meter square dose, and high dose, which is greater than 1500 milligram per meter square. Okay, so side effects at all doses is myelosuppression. It can cause GI upset, such as nausea and vomiting, especially greater than 1.5 milligram per meter square, can cause severe nausea and vomiting. Dermatological toxicities is alopecia and hyperpigmentation of nails and skin. High risk for infertility, and it can also cause secondary malignancies, such as AML. Okay. Side effects seen at high doses, that is above 1.5 gram per meter square, is hypersensitivity reactions. It can cause SIDH. It can cause cardiotoxicity, and the characteristic toxicity seen is hemorrhagic, necrotic, hemorrhagic, necrotic, perimyocarditis. Okay, so that is the hemorrhagic necrotic perimyocarditis is the cardiotoxicity seen. It can cause pneumotoxicity, it can cause hemorrhagic cystitis at high doses, right? And it can also cause, right, so all of that, and it can also cause hepatovenous occlusive disease as well at high doses. Okay, so that's how we classify the toxicity based on low and as well as high dose. Now, coming to another important drug that we very commonly give, right? So pemetrexed is the drug, and right. So usually pemetrexed is an antifolate. It acts in the polyglutamated form. It basically inhibits the enzyme thymidate synthetase, which causes the formation of deoxythymidate monophosphate from deoxyuridine monophosphate. So thymidate synthetase is the main enzyme that is inhibited in the polyglutamated form. Now, pemetrexed is usually given IV, and pemetrexed, the dose is usually 500 milligram per meter square. It is given over 10 minutes in 100 ml NS. Okay, 500 milligram per meter square. So the indications for pemetrexed are in case of non-small cell lung cancer in the radical setting, that is, post-surgery or concurrent with chemoradiation, or you can give it in the metastatic setting. There's also evidence in metastatic setting for pemetrexed. So you give pemetrexed with a platinum agent. And there's also evidence for pemetrexed maintenance based on the Paramount trial in the metastatic setting, where you give 500 milligram per meter square till progression every 3 weekly as well. Um, Now, coming to other sites in mesothelioma also, cisplatin, platinum along with pemetrexed is the preferred regimen, both in the advanced setting as well as the metastatic setting. Okay, and there also there's a provision for pemetrexed maintenance as well. Other off-label indications include in CA ovary, CA endometrium, etc., and in thymic malignancies. Okay, now coming to the precautions, pemetrexed is known to cause severe myelosuppression and mucositis. So there you give 1 week prior to injection, you give folic acid given at a dose of 0.4 to 1 milligram. So 400 microgram to 1000 microgram. It's started 7 days prior to the infusion and it's continued 7 days prior to the first administration and it's continued throughout the treatment up till post 21 days after the treatment. Okay. And apart from that, you also give vitamin B12, 1000 microgram, and you give that 1 week prior to the first injection and you repeat that every 3 cycles. You also give dexamethasone 4 mg. You give it on day 0, day 1, and day 2, 4 mg BD. Okay, that is to prevent skin toxicities. So those are the precautions you need to take. The toxicities include myelosuppression, mucositis, GI toxicities, as well as skin toxicities in the form of rash, pruritus, and also it can cause an active form rash, can cause pruritus as well, and can cause keratosis of the skin as well. So that is pemetrexed. Now, okay, I think I'll take a 30-second breather. I'll just have a sip of water. Okay, now coming to the next one is 5-fluorouracil. So that is a pyrimidine analog, and basically it acts by converting to 5-fluorodeoxyuridine monophosphate that inhibits the thymidate synthetase enzyme, which prevents the formation. So this fluorodeoxyuridine monophosphate inhibits thymidate synthetase, which prevents the formation of deoxythymidate monophosphate, which is required for DNA synthesis. It also binds to DNA and RNA and prevents its function. Okay. So fluorouracil is usually given in the IV format, and it is also it can also be given as a topical application in certain skin conditions, right? And so basically, so that's the mechanism of action. It's given in IV form. It can also be given in topical form. Now coming to this, the indications where it's given, there's a wide range of indications. So usually given as part of the modified FOLFOX6 regimen, which is given in all your GI malignancies such as your CA colon in the adjuvant setting as well as the metastatic setting, in CA rectum as well, in gastric and esophageal cancer for patients who are not fit for FLOT regimen, in hepatobiliary cancers in the second line setting, and in neuroendocrine tumors as part of neuroendocrine tumors that are high grade, right? That also can give FOLFOX. Then you have FOLFIRI regimen, which is once again given in CA colon. You have modified FOLFIRINOX, which is given in CA pancreas, both in the adjuvant setting and metastatic setting. You have also NALIRIFOX given in the metastatic setting of CA pancreas. You have head and neck PF and TPF regimen. You can give it with concurrent RT, especially an example would be in anal canal where you combine it with mitomycin C and 5-FU, right? So those are all indications. Now, coming to so you combine it with leucovorin because leucovorin stabilizes the 5-FU thymidate synthetase complex, right? So it enhances the efficacy of 5-FU. Now, coming to the toxicities, it can cause myelosuppression, it can cause mucositis and diarrhea, it can cause hand-foot syndrome, right? It can cause cardiac toxicity. So it can cause MI by cardiac vasospasm during infusion, especially to 24-hour infusion. It can cause neurological toxicity. It can cause eye problems like conjunctivitis and blepharitis. And it can cause various skin toxicities as well. Okay. So that's 5-FU for basics of 5-FU. Now, next is osimertinib. So osimertinib is a third generation anti-EGFR tyrosine kinase inhibitor. It is given, so it mainly acts predominantly on the mutated form of EGFR receptor rather than the wild form, and it prevents activation of downstream pathways that cause cell growth, right? Such as the PIK3C AKT pathway as well as the RAS-RAF pathway. So now osimertinib is usually given orally. It is given, you can give it before or after food, it doesn't matter. And basically, if you look at the precautions prior, you need to do an CBC bio, you need to do an echocardiogram with an ECG because it can cause cardiomyopathy and QTC prolongation. And when it comes to the indications for osimertinib, usually give osimertinib in the adjuvant setting post-surgery based on the ADORA trial for 3 years, 80 mg OD for 3 years. You give it post-CTRT based on the LAURA trial till progression. You give it in, in patients who have EGFR mutation status upfront single agent, or currently you can combine it with chemotherapy based on the FLORA-2 trial upfront, or you can, right. So those are the two settings upfront. So osimertinib single agent, or you can give it combined with chemotherapy based on the FLORA-2 trial, right? You can also give in second line setting post first or second generation TKI for those who have T790M mutation as well. Okay, so post progression first or second generation TKI with T790M mutation, you can give it in the second line setting. Okay, so coming to the toxicities, it can cause cardiomyopathy, it can cause QTC prolongation, it can also cause rash as well as diarrhea and mucositis, although it is less than the first and second generation TKIs, it can also cause ILD. So those are some of the toxicities of osimertinib. So coming to another important drug that we have here, I'll just take a quick breather. So you have temozolomide. Now, when you look at temozolomide, so basically, right. So yeah, so coming to temozolomide, it is basically an alkylating agent, right? But rather than alkylating the N7 position of guanine, it is slightly different, right? Right. So it is a cell cycle non-specific alkylating agent, right? So it basically binds to the N7 or O6 position. So N7 and O6 position of guanine, right? And it basically leads to the formation of DNA cross-linked adducts, and it leads to loss of breaking up of the DNA strand, right? So usually when it comes, it is you give it empty stomach always, and you give it orally, and you give it 1 hour before food, right? Because food reduces the absorption, and it has good blood-brain barrier penetration. Okay, now coming to the indications, you generally tend to give it with glioblastoma. Glioblastoma, you give it as per the STU protocol. So you do maximal safe resection with RT 60 grain 30 fractions with concurrent temozolomide 75 milligram per meter square. There you also give septran prophylaxis because it can cause pneumocystis. Then you give adjuvant temozolomide 150 to 200 milligram per meter square day 1 to 5 every 28 days, right, for 6 months. So that is in glioblastoma. And anaplastic astrocytoma, the treatment is so grade 3 or grade 4 astrocytomas, right? Not glioblastoma. There uh, you give it as part of adjuvant treatment. So there the treatment is maximal safe resection, RT alone, followed by adjuvant temozolomide for 12 cycles. Okay. And you can also give it as part of the CAPTAIN regimen as well in neuroendocrine tumors. You can also give it in metastatic melanoma. You can give it in primary CNS lymphoma, combining it with rituximab for patients who are ineligible for methotrexate or intensive chemotherapies. So those are some of the indications where we give it. So here it is moderately emetogenic. So always give it with an anti-emetic agent such as ondansetron. So you should avoid sun exposure. It can cause photosensitivity. Like I said, with radiation, it can also cause pneumocystis. So you always give septran prophylaxis. Okay. And it has higher efficacy in a methylated MGMT. If the MGMT promoter site is methylated, it has higher efficacy, right? Because DNA repair is suppressed if MGMT promoter site is methylated. So this can cause myelosuppression, predominantly thrombocytopenia, nausea and vomiting, hepatotoxicity, pneumocystis infections, sensitivity, and can also cause MDS and AML as well. Okay, right. So coming to bleomycin is basically an antibody derived. It is a bacteria-derived antibody chemotherapy agent, and basically bleomycin, it acts by so it binds to copper and gets transported into the tumor cell, and there it binds to iron in the ferrous form, and it gets converted in the presence of oxygen to the ferric form, right? So that is how it binds. Now it is then right. So once it's in the ferric form, it causes it acts as a free radical and causes cell damage, right? So that is how bleomycin acts. It is inactivated by bleomycin hydrolase, right? Bleomycin hydrolase, and so that's that. So now, how do we give it? You give it usually in the IV form. You can also give it as part of an intrapleural injection when you're trying to do pleurodesis, right? And the it is predominantly metabolized by the kidneys. So creatinine monitoring is important. And now, coming to the indications, it's given as part of the BEP regimen in germ cell tumors. It is given as part of the ABVD regimen, the escalated Biakov regimen, and the in case of Hodgkin's disease, it is given 60 units for pleurodesis, right? So those are some of the indications. Now, coming to excuse me. Yeah. So coming to the precautions, usually it's what are the contraindications? So it is uh, uh, absolute contraindication is if the it can cause pneumonitis, right? So DLCO is less than 30. Relative contraindications are if DLCO is 30 to 60, if there's a history of smoking, if the age is greater than 40 years of age, if there's COPD, if creatinine clearance is impaired, or if there is you're expecting to do thoracic surgery, right? Or if there's oxygen requirement of FiO2 greater than 30 or more. So that is also one of the precautions you should take. The FiO2 should not be greater than 30 while giving bleomycin. Right. So now coming to the toxicities of bleomycin. Bleomycin can cause pneumonitis and ILD, right? Especially at a dose of 400 units or more. It can also cause skin toxicity such as keratosis of the skin and nails. It can cause, striae formation, and most characteristically, it can cause the flagellated erythematous hyperpigmentation of the skin. Okay, which is also called as whiplash, uh, markings on the skin, right? So that is bleomycin for you. Now coming to rituximab, right? So rituximab is an anti-CD20 antibody. This is very commonly asked, especially if the older examiners come, right? So rituximab is an anti-CD20 monoclonal antibody, and basically it binds to the CD20, which is expressed on a wide variety of lymphomas, predominantly B-cell lymphomas, and it leads to inactivation of the downstream pathways and causes cell death, right? It also causes cell death by causing complement-dependent cytotoxicity more than uh, antigen-dependent cellular cytotoxicity. So CDC is done more than ADCC. Okay. Now coming to rituximab, is given as IV infusion. The infusion protocol is 50 milligram per hour for the first 30 minutes. And then every 30 minutes, if tolerating, you increase it by 50 milligram per hour, maximum of 400 milligram per hour. Subsequent infusions, you can give it 100 milligram per uh, hour for every 30 minutes and increase it every 30 minutes if tolerating, maximum of 400 milligram per hour. It's also given in the IT form up to 50 milligram. It's also given in subcutaneous form at a dose of 1,400 milligram per milligrams subcutaneously in DLBCL and follicular lymphoma, right? So indications are many. It's given in all B cell lymphomas, the DLBCL, Burkitt's, follicular, mantle cell, etc. Right? So now coming to the precautions that you need to take. First of all, hypersensitivity reactions. So you need to give it with that particular infusion protocol in mind, right? And another thing is that it can also cause suppression of the B cell function. So B cell function gets suppressed. Immunoglobulins are less likely to be formed. So after giving rituximab for 6 to 12 months, there'll be immunosuppression. So the patient you need to watch out for infections. Another thing is it can also cause flare of hepatitis B. So always do HPSAG, anti-HPC, IgM, and total. And if any of these are positive, do HPV DNA PCR. And if they're positive, you need to give tenofovir along with that prophylactically. Okay, now coming to the toxicities, it can cause hypersensitivity reactions, it can cause pneumonitis, it can cause skin toxicities, especially if given subcutaneously. It can cause ILD reactions. It can also cause flare of hepatitis B. It can also cause JC virus flare leading to multifocal leukoencephalopathy. It can also reactivate herpes simplex virus, etc. So those are some of the toxicities of rituximab. Right. So I'll just take a 1 minute breather there. So I hope you're getting all these drugs. This is how you say it. Just say it in a flow. Okay, take a deep breath and just say it in a flow. And the good thing in the exam is that most of the examiners will allow you to select your drug. So you can say something that you're confident with. Okay. This is almost like my exam because I'm trying to say most of this off the top of my head. Okay, so let us go on to the next drug. So the next drug is acalabrutinib. So acalabrutinib is a Bruton kinase inhibitor. It by binding to this Bruton kinase enzyme, it inhibits the B cell receptor signaling. Okay, so it binds to the C481 component of the ATP binding site of Bruton kinase. It inhibits the downstream pathways of B cell signaling, right? Now, acalabrutinib is usually given at a dose, it's given orally. It can be given before or after food. It's given at a dose of 100 milligram BD. You should avoid the use of PPIs while giving it, right? Now, coming to the indications are predominantly in first line setting in CLL. If treatment is indicated, you give it till progression. And also, it can be used in second line setting in cases such as mantle cell lymphoma. It can also be used in post multiple lines in primary CNS lymphoma as well. Okay, so those are some of the indications for acalabrutinib. Now, you should always do a cardiac function test prior to giving acalabrutinib because it can cause cardiac toxicity and AF. You also need to monitor the baseline BP, do an LFT because it's processed by the liver, right? So those are some of the precautions that you'll take. Now, toxicities, it can cause atrial fibrillation, it can cause hemorrhage, it can cause hypertension, it can cause TLS, especially if there's a high tumor burden. It can cause joint pain like arthralgia, myalgia. It can cause infections like such as pneumocystis, varicella zoster virus reactivation, hepatitis B reactivation as well. Initially, while giving it, it causes lymphocytosis, it can increase the lymphocyte count, but that's seen in the first 2 months. It can also cause myelosuppression. It can cause mucositis, rash, and diarrhea, right? And apart from this, it can also cause headaches as well. Okay, so headaches are also seen specifically with acalabrutinib. Compared to ibrutinib, it has less cardiac toxicity such as AF and hemorrhage and hypertension, so it is preferred over ibrutinib. Okay, so I hope you got all of that. Now, coming to tamoxifen. So tamoxifen is another drug that is commonly asked in these exams, okay, that you need to be prepared for. So tamoxifen is a selective estrogen receptor modulator, right? So based on the site, tamoxifen can have antagonistic effects or can have agonistic effects. Okay, so so basically it it has agonistic effect on the liver, bone, uterus, and hypothalamus, and it has antagonistic effect in the ER alpha receptor of the breast tissue. Okay, what decides antagonistic and agonistic is the presence of repressors, co-activators or co-repressors. So if you have more co-activators, it will cause a agonistic effect. And if you have more co-repressors, you will get an antagonistic effect, like you see in the breast tissue, right? So that is how tamoxifen works. Tamoxifen is taken as an oral tablet. It is metabolized primarily by CYP3A4 enzyme and also by CYP2D6 enzyme. So you should avoid drugs that cause these interactions as well. Okay, so where is tamoxifen given? Tamoxifen is usually given in breast cancer. It can be given in the to prevent breast cancer, if you have a Gale model score of 1.67 percentage, if you have LCIS, right, based on the NSABP P1 trial, you can give adjunct tamoxifen in premenopausal patients for up to 10 years post radical treatment. You can also give it in the metastatic settings post multiple lines, although it is not currently that preferred in the metastatic setting. You can also give tamoxifen in hormone positive endometrial tumors, where you can combine it with medroxyprogesterone and tamoxifen, right? Hormone positive endometrial tumors. So those are some of the settings of tamoxifen. You can also give it as a part of metronomic chemotherapy with methotrexate and tamoxifen, which is given in a wide range of cancers such as Ewing's tumor, post multiple lines, right? So those are some of the indications of tamoxifen. Now, coming to the toxicities, it can cause hot flushes, right? Which is due to the agonistic effect on the hypothalamus, right? It can cause right. So it can cause hot flushes. It can cause what do you call it? Vaginal dryness. It can cause headaches. It can cause fatigue. It can cause thromboembolism, right? Which is very rare. It can cause it can also cause uterine sarcomas and uterine carcinomas, which are also very rare. It can cause wide range of eye problems such as cataract, keratopathy, etc. And rarely it can also cause thrombocytopenia and LFT dysfunction, including hepatic fibrosis. Okay, so that is tamoxifen. Now, coming to the next one, as you can see over here, right? So this one is basically a myeloma drug. It is daratumumab, right? And basically daratumumab is a anti-CD38 uh, inhibitor. It's a monoclonal antibody that inhibits anti-CD38, which is expressed on the plasma cells that you see in myeloma, right? And that inhibits the downstream pathways. Now, coming to how you, right. So that's the mechanism of action right over there. And basically, it also causes complement dependent cytotoxicity, antigen dependent cellular cytotoxicity, uh, and it also causes cell death by these mechanisms as well. Okay. Now, usually daratumab is administered in the IV form and the subcutaneous form. When you give it in the IV form, usually in myeloma, you give it 16 milligram per kg every weekly for 8 weeks, then 16 milligram per kg every 2 weekly for 8 cycles, and then you give 16 milligram per kg of monthly maintenance. Okay. And in the setting of subcutaneous form, you give 1800 milligrams subcutaneously, okay, over 5 minutes, right? So special considerations, so the indications include in the setting of upfront setting in myeloma, where you give Dara VRD based on the Perseus trial, and you give 4 to 6 cycles, you do transplant, and there's no role for daratumab maintenance in that setting. You can also give in the second line setting, either with, as part of various regimens. In that setting, you can consider daratumab maintenance. Okay. So second and third line setting also can give, but first line setting is the current standard of care actually with VRD. Okay. And another thing to note here is that you can also give it as part of amyloidosis, right? You can give Dara Cybordi, that is shown to have a PFS benefit over Cybordi alone. You can also give it in high risk smoldering myeloma, where you can, daratumab has found to decrease the chance for progression to myeloma, right? So those are some of the indications of daratumumab. Now, coming to the precautions, it can cause infusion reactions. So here also you can consider using, so someone asked a question, right? Where all you use these microfilters. So this is also one area where you can use the 0.2 microfilter, right? And you have to give it as per the infusion protocol, right? And you need to give pre-medications with diphenhydramine, with paracetamol and dexamethasone, right? So dexamethasone is given 20 mg on day 1 and day 2. Usually we give this dexamethasone as part of myeloma protocol, so that is enough. But you need to also have diphenhydramine and paracetamol, right? You also need to check the blood group, because sometimes there can be misreading of the blood group later on when you check post giving daratumumab. Also, another thing is it is an IgG antibody, so it can also cause misreading of the protein electrophoresis as well. Okay, now coming to the toxicities, it can cause myelosuppression, it can cause infusion reactions, it can cause respiratory infections and reactivation of herpes zoster virus. It can cause fatigue, arthralgia, and myalgia, and it can cause GI toxicities as well. Okay. So that is daratumumab. Now, coming to this next drug, that is pegfilgrastim. Okay, so pegfilgrastim is usually used in patients to increase the counts, right? So let us look at the mechanism of action of what it does is it prevents the binding of the stem cells to the bone marrow niche. Okay, so what it does is it can do two things. So count in case of neutropenic prophylaxis, it acts by causing activation of the intracellular signaling pathways, primarily the JAK and STAT pathway. Okay, and this leads to increase in the counts. It can also be used for stem cell mobilization in case of your auto transplant with the patient, and allo transplant, you do it to the donor, right? So in that case, it prevents the CXCR4 binding with the SDF1 on the bone marrow niche. Okay, so it prevents that interaction and causes release of the stem cells out of the marrow. So that's also used for stem cell mobilization. Okay, now with pegfilgrastim, where are you need to know primary prophylaxis and secondary prophylaxis. So pegfilgrastim is used in case of primary prophylaxis in patients which have in regimens where you have a high risk of febrile neutropenia greater than 20%. Okay, so it is used in cases such as your VIP regimen, your TIP regimen. It is used in the VAC-IE regimen. It is used in your TCHP regimen. It is used in your TC regimen, right? It is used in Doston's AC. And usually pegfilgrastim is given at a dose of 6 milligram subcutaneously, and it is given 24 to 72 hours after giving your right. It's given 24 to 72 hours after giving your last chemotherapy regimen, right? And what are the toxicities of pegfilgrastim? Let's quickly go through that. So, right, it can cause severe bone pain, which we see in our patients. It can rarely cause splenic rupture. It can cause ARDS. It can cause anaphylaxis, right? And it can cause capillary leak syndrome. And sometimes it can also cause MDS and AML, although that is very rare. Okay. And in patients with sickle cell anemia, it can cause sickle cell crisis. So those are all the toxicities of pegfilgrastim. Okay. Now coming to the next drug, which is bortezomib. So bortezomib is a protease inhibitor, right? And it is a reversible inhibitor of the 26S proteasome. So basically, so it inhibits the 26X proteasome, which prevents the proteolysis of various proteins, such as the B alpha degradation, right? The P53 BID and BAX, and P21 and P27. So IKB alpha degradation is reduced. That leads to increase in apoptosis, decrease in proliferation, and decrease in angiogenesis. So it by decreasing reducing the degradation of IKB alpha, it has anti-tumor effects. It also causes P53 stabilization and inhibition of degradation of BID and BAX, which leads to increase in apoptosis. It also causes P21 and P27. Can you yeah, someone is, yeah, okay. So it can also cause P21 and P27 stabilization, which leads to decrease in proliferation. So it decreases the proteasomal degradation of various components, which leads to anti-tumor effects. Okay. Now, bortezomib is given IV or subcutaneous. It has equal bioavailability, right? It's metabolized by CYP450 system of enzymes. So inducers and inhibitors have interactions. It is given usually in myeloma, right? So myeloma is where it's usually given as part of the VRD regimen, right? It is also given in your Waldenstrom macroglobulinemia. That is another setting it's given in. You can also give it post multiple lines in activated B cell, DLBCL as well. It has been tried in that setting as well. Okay, so special considerations are, so the dose is usually 1.3 milligram per meter square, and it is given subcutaneously, usually in the thigh. So the doses are the special considerations are metabolized by liver, so you have LFT dose modifications. There's no renal dose modification. It should be used in caution with patients on antihypertensives because it can cause syncope, right? And apart from that, it can also cause your herpes zoster activation. So you should also give prophylactic medication for the same in the form of Asivir. Okay. Now the toxicities includes fatigue, malaise, right? It can cause diarrhea. It can cause myelosuppression in the form of thrombocytopenia, right? It can cause infections. It can also rarely cause cardiac failure as well, LV dysfunction, and QTC prolongation. It can also cause pneumonitis as well. So that's how you give, that's all the details regarding bortezomib. Okay, now coming to imatinib. Imatinib is so this is one of the common drugs they can ask you. Imatinib is a multi-kinase TKI. Sorry, it's a tyrosine kinase inhibitor that targets the BCR-ABL protein product, right? So it binds to the ATP binding pocket of the BCR-ABL structure, and it inhibits the downstream pathways. Imatinib is given orally. Usually take it right after food along with a glass of water to prevent nausea and vomiting. It is metabolized primarily by the liver. Okay. And now coming to the indications, it is indicated in CML-CP at a dose of 400 mg OD. It is also given in pH positive ALLs, although there you prefer dasatinib rather than imatinib because it has better CNS penetration. It is also given in GIST, right? So GIST it's given if you have in the adjuvant setting in intermediate and high risk for 3 years. In metastatic setting, you give it till progression as first line therapy. If you have an so if you have a c-KIT exon 11 mutation, you give it at 400 mg OD. If you have c-KIT exon 9 mutation, give it at double dose, 800 mg OD. Okay, it is also given in chronic eosinophilic leukemia. It is given in systemic mastocytosis, etc. So those are some of the indications. Also in chondromas, it is given. Okay, at a higher dose of 800 mg OD for those patients who are unresectable. So now coming to um, the toxicities of imatinib, it can cause uh, peripheral fluid accumulation, periorbital edema, pedal edema. It can cause myalgia. It can cause LFT dysfunction. It can cause QTC prolongation. It can cause skin toxicities such as hyperpigmentation. It can cause lichenoid features. It can cause acneiform rash over the skin, right? And in long-term use, it can even cause increase in the creat clearance. So that's regarding imatinib. Now, coming to ribociclib is a CDK4/6 inhibitor. Ribociclib predominantly acts by inhibiting CDK4/6 enzyme, which prevents the phosphorylation of the RB gene, which then prevents cell cycle division, right? So if you prevent the phosphorylation of RB gene, it does not separate from the E2F transcription factor, and transcription is prevented. So it's a CDK4/6 inhibitor. Now, ribociclib, usually you give it orally at a dose of 600 mg OD, day 1 to day 21, every 28 days. Okay. So what are the, it is predominantly metabolized by the liver. There are CYP3A4 inducer and inhibitor effects. Now, you might ask, what are the what are the indications where you give it in? So ribociclib is given in your hormone positive MBC as per in the upfront setting along with AI, as well as in the second line setting along with fulvestrant, right? And it is also given based on the NATALEE trial in the adjuvant setting at a lower dose of 400 mg OD, right? Every 21 days out of every 28 days for 3 years, based on the NATALEE trial in patients with breast cancer who have stage 2A disease with high risk features, or all cases of stage 2B and stage 3, right? So that's where it's indicated. Now, coming to the toxicities, it can cause myelosuppression, it can cause QTC prolongation. So always monitor the QTC at baseline, day 15 and the first day of the second cycle. Look at the serum electrolytes at the start of the first 6 cycles as well. So initially you look at that. It can also cause LFT dysfunction. It can cause severe cutaneous adverse reactions, and very rarely it can also cause interstitial lung disease as well. Okay. Okay. Now this drug, they have started keeping it in exams recently, so be on the lookout for this drug. So N-HER2, that's trastuzumab deruxtecan. Okay. So trastuzumab deruxtecan is an antibody drug conjugate which consists of trastuzumab, which is an anti-HER2 targeting antibody that is bound via cleavable linker, which is enzyme cleaved within the cell, to deruxtecan, which is a which is a topoisomerase inhibitor, right? So basically, it acts by binding to anti-HER2 receptor, and the cleavable enzyme is cleaved, and deruxtecan is released, which causes cytotoxicity, right? Now, it is usually given as an IV injection. The dose is 5.4 milligram per kg. In CS stomach, it is given a dose in metastatic setting is 6.4 milligram per kg. And it is given initially as a 90-minute infusion in 5% dextrose, and subsequently as a 30-minute infusion if tolerating. Now, where all is it indicated? It is indicated in the case of breast cancers, HER2 positive breast cancers. So it was initially approved in the second line setting where they compared it with TDM1 based on Destiny Breast 3 trial, which showed a PFS and OS benefit. Currently, based on the Destiny Breast 9 trial, it is going to be awaiting approval in the first line setting where they compared it to the Cleopatra protocol of TCHP, where it showed a PFS benefit. It is also awaiting approval in the adjuvant setting for non-PCR high-risk patients, as well as for the neoadjuvant setting based on the DBL11 and DB5 trials. Okay, so these are the approvals in breast cancer. It can also be used in gastric cancer that are HER2 positive, colon cancers that are HER2 positive, and in lung cancer patients with HER220 insertion mutation. So those are the other approvals as well. Now, coming to the toxicities, it can cause cardiotoxicity, it can cause infusion reactions, it can cause, cardiotoxic infusion reactions, but the main toxicity here is ILD. Okay, ILD. So management of ILD is, if it is grade 1, there you need to, stop the drug, give steroids, and if the ILD improves within 28 days, you can rechallenge the drug. If it does not improve beyond 28 days, then you discontinue the drug. For grade 2 onwards, you always discontinue the drug. Okay, so those are some of the toxicities there. Then also deruxtecan, as we know, it is a topoisomerase inhibitor, so it can also cause mucositis and diarrhea as well. Okay, so those are some of the toxicities seen with trastuzumab deruxtecan. Okay, now this is also another, favorite of a lot of examiners that I see, that is L-asparagine. So L-asparagine is basically what it does is it is a drug that is used in two settings. I'll say the setting to mention the mechanism of action. So in ALL as well as in in NK T cell lymphoma. So basically, we know that acute leukemia cells lack the asparagine synthetase enzyme, so it requires exogenous sources of asparagine. So basically, this asparaginase, it hydrolyzes the L-asparaginase within the leukemia cells to aspartic acid and ammonia. And because it is an essential, it is not present naturally in the leukemia cells, these leukemia cells die off. Okay. So that is number one. Another thing is that it is, it is not excreted from the cell through the p-glycro, your multi-drug resistance efflux pumps, right? So it is resistance to efflux through the MDR efflux pump. So because of that, it can be used in the NK T cell lymphomas, which have this phenotype of MDR efflux pumps, right? Where other drugs won't work. So it is available in two forms, E. coli-based asparaginase and pegylated L-asparaginase. Those who have hypersensitivity to E. coli-based, you can give Erwinia-derived asparaginase as well. Okay. So now coming to the special considerations, you need to monitor for anaphylactic reactions. You need to give TLS prophylaxis in ALL. It can cause acute pancreatitis, so always do the serum amylase and lipase in between or if symptomatic. It can also cause bleeding as well. So always look at the PT-INR, APTT on baseline and throughout. It can also monitor the serum. You also need to monitor the serum glucose levels, monitor the thyroid function tests. So toxicities include, so indications like I mentioned already, NK T cell lymphoma as well as acute leukemia, right? In the induction phase. So toxicities are, it can cause hypersensitivity reactions. It can cause pancreatitis. It can cause hyperglycemia. It can cause hepatotoxicity, right? So always monitor the LFT. It can cause increased risk of bleeding, right? As well. So those are some of the toxicities of L-asparagine. Now, this is a very important supportive drug that we give, right? So that is your bisphosphonate. So zoledronic acid, usually it is given. It is basically a bisphosphonate, right? And the basic mechanism of action is that right. So it basically acts. Yeah. So right. So it basically acts by inhibiting the enzyme. By inhibiting the enzyme mevalonate decarboxylase, which prevents the formation of isopentenyl diphosphate. Okay, so what that does is that it decreases the bone turnover due to decreased bone resorption. It decreases the number of newborn multicellular units. It decreases osteoclast recruitment. It increases osteoclast apoptosis, right? So that is the mechanism of action right over there, right? So now coming to the, it is given IV, it is given at 100 ml over 15 minutes, right? It is usually excreted to the kidney, so you need to dose adjust based on the creat clearance. So greater than 60 ml per minute, 4 milligrams, 50 to 60, 3.5, 40 to 50, 3.3, and 30 to 40, 3 milligram. Less than 30 ml per minute, you discontinue the drug, right? So it is given a dose of 4 mg IV. Now, where the indications you give it in all metastatic carcinomas with bone mets to decrease the symptoms, right? And to decrease the bone-related complications. So you give it at a dose of 4 mg every 3 monthly. You also give it in osteoporotic patients 6 monthly. You also give it in case of breast cancer, in radically treated breast cancer, postmenopausal patients. You give it every 6 monthly for up to 3 to 5 years. So that is shown to have an OS benefit as well based on the EBCTCG 2015 trial. So those are indications for zoledronic acid. Precautions are you always prevent omit dental procedures during zoledronic acid because that can cause osteonecrosis as well. Okay, now coming to the adverse effects, it can cause reflux, esophagitis, ulcers. It can cause flu-like symptoms, including fever. It can cause hypocalcemia, so always give calcium supplements. It can cause renal dysfunction. It can cause ocular toxicity, such as conjunctivitis, episcleritis, uveitis, etc. It can cause osteonecrosis of the jaw. It can cause subtrochanteric femoral fractures as well. So always look out for that. So that is zoledronate. Okay. Now coming to pembrolizumab. Right. So coming to pembrolizumab is an anti-PD-1 inhibitor, right? It is an immune checkpoint inhibitor that prevents the interaction of PD-1 located on the T cell with your tumor cell, which has your PDL1. So by doing that, it can decrease the anti-immune effects of so it can decrease the anti-immune effects of the tumor, right? By binding to PD1, which interacts with PDL1 and causes anti-immune effects. So pembrolizumab is given IV. It is given as a 60-minute infusion initially, then as a 30-minute infusion. It is given in a with a it is given. So right, coming back to it. So pembrolizumab is given like I said, 60 minutes first infusion through a micron filter, and subsequent infusions give it over 30 minutes, right? Now, coming to the indications, indications are many. So you have, I'll just give 5 off the top of my head. Head and neck malignancies, you give it as per keynote 689 in resectable tumors, neoadjuvant, and then adjuvant post-surgery for 1 year. You give it in case of lung malignancies, both in the perioperative setting as well as in the metastatic setting with chemotherapy. You give it in the adjuvant setting in melanomas as well as in the metastatic setting as a single agent. You give it in kidney tumors post-resection in the adjuvant setting. You also give it in the metastatic setting, right, with your enfortumab vedotin, right? So EV plus pembrolizumab is approved there. So those are some of the indications of pembrolizumab that you need to be aware of. Now, toxicities, study all the immune toxicities, right? Such as pneumonitis, such as mucositis, skin toxicities, myocarditis, colitis, etc. All of that you need to know, and the management as well, if you can know the management, especially the common ones such as pneumonitis and colitis. And this skin toxicities, it can also cause hypocortisolism as well as hypothyroidism and thyrotoxicosis as well. Okay, so I think I'll call it a day there. You can also study NAP paclitaxel. Just look it up, read up on that. That is also very commonly asked. It is given in pancreatic malignancies, breast cancer, etc. So I think I'll call it a day there. Thank you all the best, and hope you guys do well, which I know you guys will. Just study, watch the videos, revise everything. And one more thing I want you guys to know is that tomorrow we'll do the lung cancer video. I'll call it a day. I think I'm kind of done. I think I gave my exam again through this video. Okay. Okay. Thank you all. I'll upload this video shortly. Bye.
Bye, sir. Thank you.